painful affective states. And self-destructiveness can take lots of forms other than self-mutilation, but self-mutilation is core. When you see complex trauma patients, and when you see highly dissociative patients, and you ask, have you ever gone through a period of time where you self-mutilate? What do you think the percentage of people who say yes is? Think high. Think high. So why? Why do we think that's an issue in people who have been traumatized? Why self-mutilate?
There are various reasons, I guess. I guess some people they do it to feel a sense of grounding, to make it feel real. But some of them they do it because of it's like a way of punishing themselves for guilt and all that thing.
Absolutely. Multiple motivations, right? Usually it's overdetermined, but self-punishment may be a part of it for a lot of people. But the first thing you said, I think, resonates as a very common reason, that it's a way to terminate intolerable dissociative states, to feel real when you can't feel real, or to feel anything when you feel numb. And the numb is so dysphoric that you can't tolerate it. So, and if you ask people, if we can get away from the judgmentalness that sometimes people who self-mutilate encounter, and we can just say, hey, what's going on? Why'd you do that? They'll tell you. And lots of times it's to terminate an intolerable emotional state. So it really makes sense. The problem with self-mutilation, like with a lot of things, is that it works really well for people who it works for. It doesn't work for everybody. There's some biological differences, and there's a lot of speculation about what that might be, but it's going to be done. Suicidal preoccupation. So how is this different from suicidal ideation? So preoccupation, what is that? What's the experience? What are patients going to tell you when you ask them about suicide? Complex trauma folks will say, I think about it like all the time, or a lot of the time. I'm not going to do it, but it always comes to mind as a way out of this pain. And sometimes, when I'm really distressed, I'll think about it on purpose. It'll be the fallback position to know I don't have to suffer like this. So I will consciously keep it on my mind, but even when I'm not trying to think about it, it's often not. So a chronic preoccupation with suicide. Difficulty modulating sexual behavior, and that goes both directions, where there can be suppression of interest, desire, physical responsiveness, or sort of a hypersexuality. People will report having lots of sexual partners and having sexual encounters they didn't intend to, but that were not sexual assault. So they find themselves in situations they consented to, but without any intent to really do that when they set out. So, and then excessive risk-taking. Second category is alteration in attention or consciousness, and it includes amnesia, which is a symptom of PTSD as well. And transient dissociative episodes. So depersonalization, derealization. These tend to occur under stress or during boring lectures. So, oh come on, that was fun. Some of you are experiencing this right now. But the real sort of issue, all of us have alterations in attention of consciousness, right? But these are ones that sort of go beyond what might be considered to be expected for most of us. These are folks who have significant periods of amnesia. They may have more global amnesia for major chunks of life. You'll hear people say things like, I don't remember anything before third grade. I don't remember anything before age 6. So they have significant amnesia. Okay? In the absence of some medical reason or head trauma, I mean, just psychogenic, true psychogenic. The third area that has really been identified, and a lot's written about this, are changes in the person's view of themselves as a result of that kind of long-term trauma. So think about, how does the sense of self change when you're subjected to violation over time? So perceptions of ineffectiveness or A damaged self-efficacy is pretty common. A sense of being permanently damaged or stigmatized. People will walk around feeling this and really have extreme difficulty relating to other people. Some people believe it's visible, that other people will know through osmosis that they are this way. And you'll hear that. You will see that if you buy the notion of transference. I hope we can still say that too. You okay?
Yeah.
Everybody good?
Yep.
If you buy the notion of transference, it will emerge there. And typically emerges rapidly. I usually pursue it within the first couple of interviews. We'll talk about traumatic transference. I don't wait. I really ask about it. It's really important. It goes along with this, the D word, shame. Actually, it's the S word, but it's D up here. Shame is ubiquitous when people have been traumatized interpersonally. You don't get away from it. Very few people will not acknowledge that there's some sense of shame for being violated repeatedly, tortured, abused. Ever see a trauma survivor feel guilty about something they have no control over? We're just built that way, right? We will accept responsibility or guilt for things that we couldn't cause, couldn't prevent. And to some degree, that can be adaptive in the very beginning. Right? A lot of people believe that the guilt serves a protective function because feeling like things were so out of control, there was nothing you could do, that you were helpless, this works. So some people believe that guilt is an initially good adaptation to trauma, except if it persists. By definition, we're talking this is embedded now, persists. What's tough about some of these is these are not transient changes that last a couple of days. These become the fabric of someone's personality over the course of years, months to years. So can you imagine psychotherapeutically how hard the therapy is for the clients? And well, for you too, but for the patients. You're talking about significant character changes as a result of these kind of experiences. In attachment relationships. It's like the worst way to mess somebody up, right? Have a secure attachment, break it, and then traumatize somebody. Somebody's kidnapped or taken away from their secure attachments, put in a situation where they're dependent on another person, and that person traumatizes them. We're not built for that too well. Yet there are people, again, remember the post-traumatic growth, there are lots of people who survive those experiences and come back and say, yeah, maybe a better person. They also have nightmares and flashbacks and that too. We're in the midst of being resuscitated. Have an MI in the midst of resuscitation. Come back later and tell you, what did you hear?
Half the body wasn't his anymore, half with the cancer, as in a lung cancer. Just saw a patient 2 days ago. They felt this part wasn't me anymore. It's very weird. So.
It's a pretty common adaptation. Sexual trauma survivors do talk about that, even the body experience. I worked on a burn unit. Part of my training for a year was on a burn unit. And extremely high rate of depersonalization when people were in situations where they were being burned and they couldn't escape. So literally they were trapped and being burned. So the sense of kind of watching your arm be burned and disconnecting from the idea that it's your arm, even though you know it's your arm, emotionally, there was a separation, a distancing that helped the person get through it. And you imagine what the physiology of all that is. But a lot of people like to look at the physiology of these symptoms too. Dissociative disorder, NOS, is like any other NOS category. If we don't know what it is, put it there. It's not quite one of these, but sort of looks like one of these. It's this. How's that for scientific? And then dissociative identity disorder. This is the one that you said there's a lot of controversial in the trauma world. This is controversial. I spend a fair amount of my time in working with folks who have been diagnosed with this. So that's my bias, is that there's something to this. This is real. But the way it's portrayed is often this kind of a misperception or a caricature of what it really is. Okay, so that you've seen the movies like Sybil and Three Faces of Eve. Remember those? You guys really need to watch more movies. That's really where you're going to learn about some of this.
And the movie interest group among the I don't know who
Glenn Gabbard. Didn't Glenn Gabbard write a textbook about the movies in psychiatry? Yeah, I should look that up. What we think of when you think of dissociative identity or multiple personality disorder, was the DSM-3 term. What do you think of?